Okay, we have started recording. We are also on Facebook Live. So we'll make an official start to the program. So Assalamu alaikum, and thank you everybody for joining us today on this webinar. This is a webinar being organized by APNE for the Yar Watan series. And we welcome our participants and we welcome our panelists for today. My name is Dr. Amir Berni, and I'm the president of the Association of Pakistani Physicians of Northern Europe. And I'm moderating this program alongside my colleague, Ms. Sadaf Jafar Boy. Sadaf Jafar, would you like to introduce yourself?
Bismillah ar-Rahman ar-Rahim. Thank you, Amir. I'm Ms. Sadaf. I'm a breast surgeon and I'm an executive member of APNE. And we are honored and privileged to do this collaborative program with Yarane Watan. It's a chain of a webinar series, and I'm very thankful to all our speakers who have joined in this morning to share their experience and expertise about managing patients with COVID, particularly pregnant women and children. So we're going to spend almost, say about half an hour, 40 minutes talking about the management. And I'm sure there would be questions coming up at the end of the session, which we will address towards the end. I would request all the attendees to kindly make sure that your mics are muted at all times. And I'm sure when there are questions coming up, please put them in the chat box and we will address them once we finish all the presentations. So to start the session, we will talk about management of pregnancy in COVID-19. And I'll start off by introducing Dr. Amreen Rauf. She's a consultant obstetrician and gynecologist at Warrington and Halton Hospitals NHS Trust. She is an honorary lecturer at University of Liverpool, and she's a clinical examiner for MRCOG. So over to you, Dr. Rauf.
Okay.
Can we mute your mics up? Those other than Ms.
Press it again.
Yeah, that's fine. Thank you.
Now show your screen on the right, in the middle green one.
Okay. Just sharing my screen now.
Yeah.
Yeah, press OK. At the bottom right, on the blue screen, on the new screen.
Share.
Yeah. Okay.
Can people see my presentation?
We can see. Please carry on.
Okay. Thank you for inviting me to this webinar, and it's the hot topic of the day. I'll introduce myself first. Thank you, Sada, for already introducing me. So I'm a consultant obstetrician and gynecologist at Warrington. We are going to do this talk in two parts. I'm going to talk about the general advice we gave to the pregnant women, the antenatal care we provide during COVID infection or suspected COVID infection, and as they are admitted, what we do. And my talk will mainly be the guidelines we follow here in our system. And then I'll kindly give over to my colleague, Dr. Mara Suhail, who will talk about COVID-19 during labor and postpartum.
On the left, on the left screen. Yeah, there, anywhere. Now, press right button. Yeah.
Okay. So there has been a UCOST study about the incidence of this infection. As we know, it's covering a very small few months. In that period, 4.9 pregnant women per 1,000 were admitted with coronavirus, 427 patients in total in that period. 1 in 10 did need intensive care. Most of these patients were in the third trimester of pregnancy. That's why we keep emphasizing the precautions they need to take, social distancing they have to do, particularly in the third trimester of pregnancy. 55% of these patients were in the BAME group, the Black and ethnic minority background. That's why our guidelines say that these patients have to be fully counseled about the risks, and we have to special precautions about them. Unfortunately, 5 pregnant women did die during this COVID infection in pregnancy. This is unclear if coronavirus actually caused the death. The transmission of the virus to the baby has been noted to be uncommon. The general advice we give to the patients is that they should attend routine antenatal care unless they have symptoms or they have been in contact with people who have symptoms and they're self-isolating. All units should have teleconferencing and video conferencing capabilities. The record system should be electronic so that it can be retrieved easily. Patients who have symptoms need to defer their appointments for 7 days. Other general advice we give for women who are self-isolating due to contact with symptomatic patients should have their appointment deferred for 14 days, and they should remain in isolation for 14 days. Women of Black and ethnic minority background should be advised of being at high risk of complications of COVID-19. Visitor restrictions should be done. The partner is allowed in labor and to some of the wards. Recently, we've eased the restrictions and have allowed 1 visitor other than the partner too. Service modifications due to the infection. We have needed to reduce our induction of labor. So we induce labor only where it's medically indicated. All the non-medical inductions like social requests and all, they need to be not considered. We are improving on our outpatient induction of labor so that patients have least admissions to the hospital. And when they come, they are in labor, and then they have their baby and they go back. So that hospital stay is limited too. We are reducing our routine growth scans. So in our hospital, the routine growth scans used to be done from 28 weeks onwards for singleton pregnancies. Now we've reduced them, and they start from 32 weeks and then another scan at 36 weeks. The intrapartum services should be safe. Staffing should be minimum. Only those who are required should stay in that room or in the vicinity. There should be adequate emergency, obstetric, anesthetic, and neonatal care. Women should be admitted, and women who are admitted in labor or due to other causes in the hospital should have a single asymptomatic birth partner. If the birth partner has COVID symptoms in the last 7 days, then patient should have another symptom-free partner. On attendance, all birth partners are asked about COVID symptoms, if they've had any COVID symptoms in the previous 7 days. So as we all know, the symptoms include fever, shortness of breath, acute persistent cough or any new cough, sore throat, loss of taste or smell, wheezing, sneezing, hoarseness, and nasal discharge. Birth partners should remain by the woman's bedside and should not wander around. Yes, there are visitor restrictions on the antenatal and postnatal wards to avoid infection. There is always compliance with social distancing, which is, as all we know, 2 meters or 6 feet apart. The advice for services and pregnant women with suspected or confirmed COVID-19. When they have to get admitted, women are encouraged to use public transport or their own private transport. If ambulance is needed, the call handler should be alerted that this is a suspected COVID patient or confirmed COVID patient. At the same time, maternity staff should be alerted as well. Women should be met by staff who are wearing PPEs and fluid-resistant surgical masks. Only the absolutely necessary staff should attend the patient. Any non-essential items should be removed from the vicinity to reduce the risk of infection. All clinical areas should be cleaned after use. Women with symptoms suggestive of COVID-19. Obviously, now the test is available and they should be tested for COVID-19. We do have a rapid COVID test as well, where the results are available in an hour. If they're positive, they are transferred to isolation and donning of PPE is done. These women should stay mobile. They should be well hydrated. We know that there's a link to thromboembolism. Therefore, we have to make sure that they're mobile and they're well hydrated. On booking, if the VTE score is more than 3, they will need low molecular weight heparin. And if they are to be taught during antenatal period, there's a video link to self-inject, which they can use to train themselves. Only urgent appointments should be done in the antenatal period, and they should be towards the end of the working day if they have symptoms suggestive of COVID-19. That is all. I will now hand over to my colleague, Dr. Amara Suhail. Thank you very much for listening to me so attentively. Her talk obviously will carry on from here with labor and postnatal care. Thank you.
Thank you, Dr. Roo, for an excellent talk. I would now like to introduce our next speaker, Dr. Amara Suhail. She's a consultant obstetrician and gynecologist at North Hampshire Hospital. She's the Director of Medical Education in St. George's Hospital in Grenada, and she's an honorary lecturer at Southampton University. And thank you very much, Dr. Amara Suhail.
Thanks, Sadaf, and thank you very much, Amir, for inviting me to this forum. I feel really very privileged. As Dr. Rauf has already gone through the advice, general advice, and the antenatal care path, I'm going to cover the intrapartum and the postpartum care of women with COVID-19. And I can't start without mentioning the UCOS study, because so far this is the most comprehensive study which was done which covered the period between 1st of March and mid-April and included 427 women. And the reason why I feel that it is very important to include this study and just look at the statistics is because, of course, this pandemic has created a fear amongst the whole world. And especially the women who are pregnant, they feel very vulnerable. So even though it is kind of a scary disease, but 4.9 out, about 5 women out of 1,000 were tested positive between that period. And median age was about 34 weeks. So, however, I mean, the important thing for you to kind of take from this statistics is that only 9% women, they needed level 3 critical care, and 5 out of 427 sadly died. And because they tested positive, we are kind of relating the deaths to COVID-19. However, it could be due to the coexisting factors. The mean gestational age at birth was 38 weeks, which is again a good news because most of them, they delivered after term, because term starts from 37 weeks onwards. Less than 1/3 women, they had preterm deliveries, 47% because of the maternal compromise, 15% for fetal compromise, and only 1 in 10 babies, term babies required an admission, neonatal admission. So which is again, like, not too bad. Now, I mean, after mentioning the statistics, I'm just going to go over to how these women are looked after when they are in labor. So first, I would like to talk about women who are tested positive, but they remain asymptomatic. These women, they are advised to stay at home and come only if necessary. However, we should take the opportunity to discuss about plan of care in advance, which includes the place of delivery, whether it is a hospital delivery or a low birth care units or at home. And we should also take the opportunity to talk about electronic fetal monitoring, because at the moment it's not recommended to offer all women who are asymptomatic positive patients to have electronic fetal monitoring. However, in view of the uncertainty of this disease, if a woman wishes to have, I don't see any reason why they can't be offered. So if, however, a woman is symptomatic, whether it is a confirmed positive or there is a suspicion and we are still waiting for the test result, they should be advised to self-refer if their symptoms are worsening or there is deterioration of the condition. However, if they've got mild symptoms and they are in labor, they are advised to stay at home and wait for the labor to establish. However, it is very important for them to be advised regarding the symptoms of deterioration of the disease, so that they are aware of when to attend the hospital. And when they attend the hospital, a careful history should be taken, which includes their past medical as well as obstetric history, because sometimes, we have got a tendency to be distracted because of the COVID-19. It is very important for patients who are positive to know the details, because we may be focusing on COVID and not other things. So very, very important. And then if the women, they've got a planned cesarean section, or they have to attend for planned induction of labor, that plan should be deferred for at least a week if there is no risk in delaying their delivery. And then however, if there is a need for urgent intervention, then we should make possible arrangements that Dr. Rauf has already talked about. And that arrangements should be multidisciplinary plan of care, and the women should be cared in isolated suites, or depending on their condition, the place of their care is decided. Main focus of their care is to prevent avoidable perinatal morbidity as well as mortality. And the focus should be to provide a safe women-centered care. On admission, which is a usual practice, to take all the fetal and maternal assessments, including temperature, pulse, but oxygen saturation is also included into their observations. Labor assessment should be performed, and again, if there is no sign of established labor, they should be kept in the isolation ward. And if they are in labor, then they should be offered continuous electronic fetal monitoring, because there is a possibility that there could be fetal distress is linked with COVID-19. And women who wish to have water birth, they should be discouraged. And that is because there is evidence of presence of the virus in the feces, which can cause cross-contamination of the water, which is, of course, not good for the staff looking after them. Very important to stabilize the mother if she has got severe infection, because delivery should be deferred until the mother is fully stable and the multidisciplinary team is involved in their care. We should have low threshold to start antibiotics, and that is because we should, as I said previously, that we could be distracted because of COVID-19, but the reason for somebody to present with pyrexia or other symptoms of sepsis could be other coexisting infections. So antibiotic cover is very, very important. And as I said, always keep other differentials in mind when we are making a plan of care. So if they present in preterm labor, very important to offer them steroids and magnesium sulfate. However, if we think that the woman requires urgent intervention, then the delivery should not be delayed to be able to offer steroids or magnesium sulfate. If a patient is on aspirin for previous history of preeclampsia or hypertension, it is best to stop aspirin, because there has been an association of thrombocytopenia and COVID-19. Even though we say that COVID-19 is a hypercoagulable disease, but one has to be mindful of the possibility of thrombocytopenia. Then we should also look for signs of decompensation, and they are increased oxygen requirement, increased respiratory rate despite oxygen therapy, and if a woman complains of drowsiness despite normal SATs, consider it as a symptom of deterioration. In addition to that, acute kidney injury is also linked with COVID-19 infection. The regular observations should be hourly vital signs along with oxygen saturation, and oxygen titration should be aimed to keep the saturation of more than 94%. During birth, only a birth partner should be allowed, and they are advised not to roam around, because there is a risk of spreading the infection through this. Minimum staff members should be involved, and they should take care of the proper PPE when they are looking after the women in isolated wards. And they should have a discussion with regards to epidural, because it is very important to offer them pain relief in advance. Input-output chart should be maintained to keep a neutral fluid balance, because you don't want to push too many fluids in women who are already in the state of ARDS, and that because it will complicate the situation. And thromboprophylaxis with low molecular weight heparin should be considered, because, as I mentioned before, due to the hypercoagulable nature of this disease. For pain relief, Antonox is considered to be safe, and it is not an aerosol generating procedure. However, it should be used with a single patient microbiological filter. Women should be encouraged to consider epidural, that is to minimize the risk of requiring GA at the time of emergency. And of course, if they need a Cat 1 section, we have to follow the protocol for full PPE, including masks and visors and the rest of the kit. And women should be warned in advance that in a category 1 situation, the procedure could be delayed for the proper donning by the staff. However, if the general anesthetic is given, then the donning should be done before induction of the general anesthetic. And those who are involved in looking after these women would understand that with PPE, it is very difficult to communicate with the rest of the team, which is very important at the time of emergency. So that is why it's advisable to use checklists with closed loop communication to avoid any kind of breach of communication. I'm not going to go through these slides. These are all the guidelines that most units in UK have adopted after collaboration of various societies and associations with regards to pain relief in labor and during delivery. So I'm quite happy for you to share these slides for reference if you want after we finish the webinar. So now moving on to the postpartum care. The important thing is that mother and the baby should be kept together in the immediate postpartum period. Of course, like women will be concerned about the well-being of the baby, but one must remember the benefits of breastfeeding outweigh the potential risk of transmission through breast milk. However, at this time, we should offer support to parents in their feeding choices, and we should not impose any of our choices on them. It's their choice, and they do decide on what is the final verdict. With regards to breastfeeding, as I said, there is no contraindication to breastfeeding. However, women should take precautions to avoid the risk of transmission to the neonate, and that includes wearing a mask, washing hands before breastfeeding, and not touching the breast during the breastfeeding. And if they are in the hospital and they need to be using breast pumps, then they should be dedicated for the woman only and should not be shared, of course. So moving on to the postpartum thromboprophylaxis, as I previously alluded, it is very important to start them on low molecular weight heparin as a prophylaxis, which should be continued for 10 days after birth. However, depending on the VTE scoring, if they qualify to have therapeutic doses, then the dose should be increased. And because of association of COVID-19 with the thrombocytopenia, if thrombocytopenia is detected, we should stop thromboprophylaxis and seek advice from the hematology. Now, arguably, mental health is as important as physical health, and especially for those who have got pre-existing mental health conditions, they need more support. So it is very important for the mental health staff to provide them all the information about whatever support is available, because women are very vulnerable at this point, not only because of the illness, but the general kind of response after delivery because of their pre-existing mental health. So adjustment of medication is required, and they should be encouraged to bond with the baby with the support from the staff who have been previously looked after them with their mental health. And if you look at this Venn chart, it will show you all aspects of women's mental health, and we have to be somewhere in the middle, making sure that all these aspects are taken care of and women are supported fully to make sure that they are in a safer environment along with their baby. And of course, it would be important to talk about domestic abuse, and we all would be aware that domestic abuse has increased with this pandemic, and that is because of the isolation, because of their vulnerability, financial situations, and of course, like all the household, they are sticking together. So the risk of abuse has gone up, and we should be looking out for the signs of any domestic abuse in a household and try to find times where we can see the woman alone in order to explore more from them. However, as I said, the most important thing is to make sure that the women are not often only offered support in their physical care, but also mental care as well as the social care. So I think I will stop here, but I'm sure you all are aware of all these things, but I hope there was something that you would benefit from. And as I said previously, I'm happy for you to share the slides regarding the pain relief in labor afterwards. Thank you very much. Thank you,
Dr. Amara Sohail, wonderful presentation. We have a question or a comment from Irfan Akhtar. So I'm going to unmute you from my end, Irfan, if you would like to ask your question or comment.
Thank you very much, Ambreen, and thank you very much, Dr. Sohail. Very interesting and very informative talks, and you always learn something when you hear from other colleagues. And I must pay tribute to you guys, because I recall that you are the only ones, other than breast people, who continue to work, and your theaters were always ongoing during this crisis. I cannot just help recall myself the poor nurse who died giving birth to a wonderful baby girl because of COVID, and that was extremely painful, and the tribute was on BBC. So I can imagine the mental health issues and the family which go through the agony of COVID. I'm just curious on the figure of 9%. To me, that sounds very, very big number in terms of total patients, because given that you are one of the cohorts of the total input into a hospital, the 9% to me who have got COVID requiring level 3 care is an extremely high number. I would be, if you could let us know that what were the outcomes of those ladies, that would be a bit reassuring. And secondly, thank you, Dr. Sohail, for pointing out the technical issue around communication during operations. And we have felt the same, especially with the advanced doffing and donning, and if you're wearing a respirator. So we, in our trust, have started using a mic, which is a Microsoft device, which kind of you can put it on your head before you put the rest of the things on, and that has kind of helped. Again, if you carry a Southern or a Scottish accent, that might be a challenge, but generally speaking, it helps in communicating with each other.
Thank you very much, Irfan. I totally agree with you. Any incidence which is more than 1% is high risk, and for me to be calling it only 9% is very unfair. But we must be mindful that this study was performed in the period where we didn't know much about the disease. And even though we have got better policies, better guidelines to offer them support and care, but still the general consensus and the general impression amongst most of the pregnant as well as non-pregnant population is that if they've got a severe disease, their risk of dying is as high as 50%. And there is, I mean, it is a controversial figure. However, for me to say 9% in the time when we didn't know about this disease as much as we know now, 9% didn't seem too bad. And I mean, of course, like it is always sad to lose any mother during the course of their pregnancy, but 5 in 100,000, it's not a bad figure, because the general maternal mortality in UK, according to the consensus between 2015 and 2017, was 9.2 per 100,000. So considering that this disease is a killer, pregnant women, I wouldn't say that they were resilient because of their age and their because most of the reproductive women, they are young, because we have seen that the disease process has been variable, and even the young people have been victims of this deadly disease. So it is from maternity, from obstetric point of view, the statistics of 5 point something in 100,000, it is not as bad as women may think it is. And that is why I think these statistics are quite encouraging for most people who are looking after pregnant population. And your suggestion with regards to the improvement of the communication, I agree with you. We are now slowly evolving, but of course, all these things, they take time. At the moment, we still haven't developed the pathways where we can use these improved communication tools. So for that purpose, we just use the kind of closed loop communication and checklist in order to make sure that we are not running behind, or we are running short of any safety issues during the induction of anesthetic or delivery of these babies in such a crisis time.
So essentially, my question was based around that. Does pregnancy, as you're saying that they are very small number, does pregnancy give you some protection because of immunodilution or anything like that?
No. I mean, there is, at the moment, we do not know. There is no evidence to suggest that if a woman is pregnant, her risk of deterioration with this disease is higher. However, if you think about any illness, whether it is viral or bacterial, women response because of the altered immunity in pregnancy would be different. So one has to take all the precautions to avoid the deterioration. But at the moment, there is no suggestion that pregnant women are more vulnerable compared to non-pregnant. But then again, the evidence is emerging, and I think we should wait for bigger studies to conclude that. At the moment, we treat them as like high-risk women, and our kind of tendency or threshold to start antibiotics is very low.
Thank you.
If you want to introduce the next guest, Sadaf.
Thank you. So we'll now move on to the pediatric section of the webinar, and I would like to invite Dr. Afzal Sawal, who's a consultant pediatrician at Royal Wolverhampton Hospital NHS Trust, and he's got a subspecialty interest in pediatric neurology. Over to you, Dr. Sawal.
Thank you very much, Sadaf, and thank you very much for inviting me over here. As I said, that Dr. Sawal, and my interest is neurology, but this COVID-19 has been affecting children or everybody across the board. So we are moving out of our comfort zone and managing children in different part of the pediatric department. Oops. Should go. Okay. Irfan has raised a very good question. It's very good talk coming up from here from the obstetric point of view, and why the pregnant women are not as much affected as the other population, and similar these things happen in the children. The question is this virus, which arises from the Wuhan in China. I mean, when it's been spreading, it's spread across the borders, everybody got affected. But some people are very resilient, and I'm sure the pregnant women, one of the resilience. Why they are resilient, we don't know yet. Probably mercy from Allah, I mean, otherwise we all would have been wiped off from the face of the earth. It is our immune system. It's our what's the change? There's something happening in our body that can something happening in our body that probably protecting us from this deadly virus. Can you hear me?
Yes, we can.
Yes, thank you.
Okay, so the children that also been, I mean, one of those things, I mean, area which we're very lucky that we are not many children are not very much affected from this COVID-19. But those who got affected, they get very unwell and they develop sort of a multi-organ problems. The numbers here is quite changing all the days because we're still going through the pandemic areas. WHO said 0.6% of all infected people across the world are children. Italy, the big studies done, they said from 5 to 9 years, they found the antibodies in 3% of them. And from 10 to 14 years, they found the antibodies against the virus in about 3.9%. Here, 56%, 56 times less than the adults, the childs are being affected. So, but this number is a very dynamic numbers because we are still going through the pandemics. I mean, yesterday it was the news, the Brazil is, I mean, on one single day, they reported the thousands and thousands and thousands of cases. So the number will going to be changed all the time. But we are very lucky. Mortality in children are very low. It's only 0.01%, which is 1 in 10,000, which is, in our department here in West Midland, none of the children, I think none of the children passed away. So that's very good. Again, this particular virus is affecting boys more than the girls. We've always been thinking why the children are not being affected that much. One possibility is they have got very robust immune system. So the body responds to the virus very well. Their B cells and T cells, which we had a very good lecture yesterday about from virologists, they're very robust and they produce antibodies and neutralize this virus. Or they can withstand this leukotriene storm better than the adults. Or the other possibility is the lungs are more compliant. So the thing is, the lungs are more compliant, so the variability of the symptoms are less vicious or less severe in the children compared to the others. But that's not the case in all children. Those who have got pre-existing conditions, this virus can be very dangerous, not only dangerous, and can be deadly, or can cause mortality or morbidity. For instance, if the children has got immune deficiency, there are many children we are looking after whose immune system is not as robust as it is, or they have got underlying condition which can affect their immune system, so the body is not being able to produce antibodies. These children are very high risk, or underlying leukemia, or any children who have got cancer problems. The two other categories, this is my specialty, the children who have got neuromuscular problem. The thing is that the muscles are weak. So they are not being able to cough up. They're not being able to get rid of their secretion. They're not being able to fight any infection. So they are very high risk children. And the other big groups which I'll be looking after, the children who have got cerebral palsy. Now, there are many children in Pakistan who have got cerebral palsy, and I'm afraid the management is quite variable across the country. And these children are a very vulnerable and very high risk because they always develop a recurrent chest problem. They have got difficulty in clearing up their chest. Their immune system is not as well developed as it should be, and their mobility is very less. So if the children who have got underlying static neurological problem like cerebral palsy, they are a very high risk children. If they get the COVID-19, mortality can be very high. But I'm very lucky. I'm here in my city of Wolverhampton. I'm looking after about 300 children who have got some static neurological problems in the range of cerebral palsy. And in the last 3 months, all of them are well, and none of them got the virus, and none of them were very poorly. Another group of the children who have got underlying condition like cystic fibrosis, chronic lung condition, bronchial asthma, chronic asthma. So that means they already have got some chronic illnesses in the body, and the COVID can affect them very badly. Obviously, there's the children who are already on ventilations. I'm looking after about 11 children who is already on ventilation at home at night. They are using CPAP or BiPAP. These are non-invasive ventilations. So these are the children who are a very high risk if they get the infections, and similarly heart conditions, or if they're taking steroid which suppress their immune system. Now, this list of the condition probably would be very different from the list of the condition in Pakistan, because this webinar is being viewed in Pakistan. You need to look after your cohort, and you find it out how many chronic illnesses children you have got. You need to protect them also of getting this virus. There are different ways of doing these things. I mean, there isn't any treatment yet. There's no vaccine, no medication working very well. Few of the antivirals coming up. Dexamethasone came very recently. They're all being affected. If the children develop, obviously they become very unwell, admitted to the ITU, required oxygen, or so on and so forth. And other than these medication, obviously the social distancing and the hand washing. And you can imagine that keeping social distancing with the children is a really challenge, is a big challenge. So what we did here in this country, in England, is we shield them. Okay, now shielding is a protective measure. This is a measure which we adopted in the last 3 months. Because all the children with the high risk, obviously you need a very firm database for that. If you haven't got any database of the children who have got a high risk, you cannot introduce shielding in Pakistan or any other part of the country. As we said, all our obstetrician and gynecologists mentioned the measurement of the management of the pregnant ladies. They're mostly around the pregnant ladies in NHS, but in our country where most of the children were born at home and deliveries happen at home, I don't know how those situations would have been managed in Pakistan, but that's a big challenge. That's a big challenge. Okay, I don't know how many of the pregnant ladies have antenatal care in Pakistan, so that's a big challenge over there. So shielding is a process where the children staying at home, not coming out at all. No non-essential contacts. And they've been staying at home for the last about 3 months. And I personally sent them a letter that they should not come out of the home at all. And you can imagine if the child has got some certain sort of disability and you just lock them in the rooms and not in the room, they lock them in the house. How frustrating it is. But doing that, the children I'm looking after, who are some of them are very special needs. They haven't. I have not have any reported case of my children who got the COVID-19 virus at all. So we are very successful in shielding process in England. And these children are staying at home, not going out, rather than the parents are also avoiding the non-essential contacts altogether, and they're staying with them altogether, and then they save them. It's such an amazing process. So it's basically a lockdown situation. So you're staying at home all the time. So these children are not being allowed to go out at all. Now this shielding is finishing in England around 13th of June, and most likely these children probably once they will be coming out and seeing the other family members. So these are the few issues here in the children's. The other problem they keep asking us, very well mentioned about breastfeeding now. This is the issue. Also, this is choices coming up, but we strongly recommend as a pediatrician that breastfeeding should be encouraged and continue, especially in Pakistan, because what happens is if you deprive the children of the breastfeeding, that can not only affect their immune system, removing the child from the mother have got a drastic effects. We are very lucky. There's not many cases reported where they found the viruses in the breast milk. There are 1 or 2, but there are odd cases. I don't want to mention those cases at all. So breastfeeding should be encouraged at all cost. Obviously, the mother should be wearing masks, hand washing, all this measures should be taken. And the second most important thing is, even at this point in time of the pandemic, we should encourage the people to have a normal childhood immunizations. Because if you do not immunize the things, forget about COVID-19, there would be outbreak of measles and the diphtheria and the and all the other infectious diseases, and the children will going to die more of those diseases rather than COVID-19. So immunization should be encouraged. In many parts of the world, there is outbreaks of, especially of the measles, and happening because the immunization program is being interrupted very badly. So breastfeeding encouraged, immunization should be encouraged. So this is a very short first part of our pediatrics presentation. Second would be from the Dr. Mansoor Ahmed, who will going to tell us about different presentations if the children get COVID-19. Thank you. Any question? I put all the European photos so that you can see that they're wearing the mask and they look so nice. Not a BME.
Can we ask questions, Abdul?
Yeah, sure.
Firstly, thank you. As usual, I wasn't expecting anything less. A very, very nice talk again.
Thank you.
And thank you for informing us about the importance of hand washing and masking, which prevails, in all population cohorts, irrespective. I don't know how mom can breastfeed and not kiss a baby. That comes very natural to mothers, but these are testing times for everyone. My question is slightly philosophical, if I may ask that, and that is that you mentioned that children have got very good immunity, and hence the protective effect of that. In fact, what we have realized over the time of the pathogenesis of the disease, it's actually the immunity which kills you. And hence we do all kind of things to dampen the immunity. I mean, we use steroids, which, the recovery trial has shown about the use of dexamethasone, and I think that dampens down your immunity. And equally, the use of, I think, just you mentioned about Pakistan, people eat less but take tocilizumab more than that. So both are IL-6, inhibitors. So is that this, are perhaps, as you second proposal which you gave, that they have got better lungs than us, and hence they recover?
I think it's a good question. To be honest, exactly, if you ask me what exactly the reason why the children are getting less, maybe Mansoor will going to be pointed more on this, but exactly we don't know yet. But obviously, immune system is one of them, because the children are very resilient now to the infectious diseases as a childhood infectious disease. We give them immunization, they develop antibodies, they fight them. Maybe their immune system not overdue like in adults do, like a leukotriene storms may not happen in children as in adults, and that leukotriene storms basically affect the adult people more compared to the children's. That's maybe the one reason. So leukotriene storm may not be as aggressive as in children compared to the adults. The second thing is, the most of the mortality is coming up from the respiratory problems in adults, and the children lungs are quite, is quite resistant or quite elastic in a sense that they haven't got any, if they haven't got any underlying conditions, they resist the disease better, or they comply more with the disease compared to the adults. For example, like most of the adult lungs been affected with smoking, and or they have got some chronic condition already going on. So the children are being blessed with these things. Mostly the younger children, their lungs are more compliant. They have got, unless they have got underlying conditions, they perform better, or they do better as far as the respiratory system is concerned. And I mean, we haven't got anyone here looked after a few children over here. We haven't got anyone who came with a severe respiratory failure. They do have respiratory symptoms, but they don't go up to the respiratory failure requiring ventilations. Most of them up to the oxygen requirement.
I think this is
So,
perhaps
both.
I think this is perhaps a very important message across, because if I recall correctly, Wolverhampton was one of the hotspots.
Yeah,
and even then, the outcome for children, as you said, being the frontline person down there, is not as bad.
Well, I mean, really surprising. It was very good rather. And I must say that out of my 300 children who have got neurodisability, and I've 11 children who have got severe neuromuscular problem, especially Duchenne muscular dystrophy, and they're already on ventilator at home. They didn't got it. I mean, shielding worked very well for them. They didn't got the virus. I mean, I was been telling to my colleague, I mean, if that virus entered to the special center where I'm working, it will go to wipe out everybody. But luckily, finger crossed, so far, so good. It's not over yet, I'm afraid.
Thank you, Dr. Sawal. Thank you very much. We are going to have another session for question and answers once our last speaker has given his talk. So may I take the opportunity to introduce Dr. Mansoor Ahmed. He's a consultant pediatrician at University Hospital of Derby and Burton NHS Foundation Trust. He's got vast experience. He's got specialist interest in gastroenterology, safeguarding children, training and education. Thank you, Dr. Ahmed.
Thank you very much indeed. And I would like to thank Sadaf and Amir for inviting me to this interesting webinar. And I'm particularly grateful to Apne and Yarane Watan for taking this great initiative and doing a series of webinars for delegates both in Pakistan as well as in United Kingdom. So Assalamu alaikum everybody, and my talk will concentrate on PIMS TS. Having had warning from Wuhan and from World Health Organization, and having known the staging of COVID-19 disease states, we knew that these children and young people and adults go through different phases or stages of the disease. And Chinese experience also informed us that most of the children, if at all, tend to stay within the stage 1 or early phase of infection, i.e. they are either relatively asymptomatic or have mild constitutional symptoms, and very few, if at all, children would progress through stage 2 or 3 of the disease. So what were our expectations then? Well, we thought before COVID-19 hit Europe and UK that we will have a very low number of cases in children having significant COVID-19 infection. Probably infection rates will be similar, but most children will be asymptomatic or have very mild disease, which probably will be managed at home. And that the critical illness and death is going to be extremely rare. We weren't sure as to whether or not there are specific risk factors or risk children, although we thought that children with immune suppression or post-transplant children on certain drugs and significant comorbidities may be at risk. And we weren't quite sure, and perhaps we are still not quite sure as to why this disease is less severe in children, and why children are so resilient to COVID-19 infection. So with this in mind, we just hope that it's not going to affect pediatrics as a whole in UK, and that has largely been true. So our first pediatric case of SARS-CoV-2 positive infection was reported from London on 26th of March, and this young child had significant comorbidities, was born preterm at 32 weeks gestation, had cleft palate micronathia, and presented with recurrent apneas. There was a definite contact with COVID-19 individual. Because of comorbidities, it was a difficult airway, and start off with LMA, and then required quite intensive respiratory support from high frequency oscillation ventilation to inhale nitric oxide, and things did improve eventually. However, the first index case of PIMS-TS, which I'm concentrating on, and I'll elaborate it further in a minute, was reported on 4th of April, again from London. This was a 10-year-old boy, previously fit and healthy, presented with fever, abdominal pain, diarrhea, vomiting, and rapidly spreading rash, had evidence of acute kidney injury and raised inflammatory markers, and he had quite significant refractory shock. So much so that it didn't really improve massively, even with 60 mils per kilo of fluid boluses, and required a number of inotropic agents to try and sustain his blood pressure. Interestingly, he was COVID-19 negative, and the clinicians looking after him wondered whether they're dealing with atypical Kawasaki's disease, although he was well beyond the age group for Kawasaki's, or whether it was a toxic shock syndrome. So they were just wondering as to what they're dealing with. The striking symptoms and some differences to Kawasaki's disease were abdominal pain, diarrhea, vomiting, and very significant shock that this child presented with, and some evidence of myocarditis. Clinicians started relabeling or naming this disease as Kawasaki's disease shock syndrome. Some people said Kawasaki disease, and more cases then surfaced over the successive days. The interesting thing in these cases was a rather non-typical myocarditis with significantly raised BNP, troponin, and strange ECG abnormalities. Some of these children had coronary artery aneurysm or dilatation, and very rarely, except 1 or 2 cases, also required ECMO. Thankfully, patients did improve with management strategies, which I'll allude to towards the end. Following a number of cases like this, NHS then issued an alert, which was emailed to all of us in the United Kingdom, that we are dealing with rare syndrome, and this alert came on 26th of April. We just wondered whether it's quite something similar to adult cytokine storm that we have been experiencing in adult population. And interestingly, it was common in Black and Asian minority ethnic group. And out of a series of 58 cases that Great Ormond Street Hospital in London reported, 40 belonged to VME background. Interestingly, the presentation was quite similar and overlapping with what we see in Kawasaki's disease and what we see in toxic shock syndrome. But the warning was also raised that the abdominal symptoms are rather unusual and common, and excessive inflammatory markers are commonly seen. And up until 2 weeks ago, well over 200 cases were reported, and we are still going through our British Pediatric Surveillance Unit reporting on a weekly basis on these cases. This then led to Royal College of Pediatrics and Childhood issuing their alert in May 2020, and they came up with the definition as to what. They said it presents in children with persistent inflammation, with evidence of single or multi-organ dysfunction and additional features which may or may not mimic Kawasaki's disease. And college recommended that we must exclude other causes of such as bacterial sepsis or toxic shock syndrome or other causes of myocarditis. And importantly, SARS-CoV-2 PCR tests may or may not be positive in these cases. And the college then came up with the presentation, and as I've already alluded to, these children present with significant GI symptoms, abdominal pain, diarrhea, and vomiting, but also typical symptoms which we would see in Kawasaki's disease, i.e. high persistent fever, skin rashes, mucocutaneous involvement, and conjunctivitis, etc. laboratory features included very high inflammatory markers, as I said, raised D-dimers, hypoalbuminemia, lymphopenia in particular, and then neutrophilia, along with thrombocytopenia and raised LTH. Where possible, where we tested IL-1, 6, and 10, those were also raised. X-ray or CT chest findings were reasonably similar to what is being seen in adult population, and ECG echo would show that some of these children also had evidence of myocarditis. This then obviously was reported more and more from Europe as well as from North America, and CDC, which is the Center for Disease Control and Prevention in the United States, then came up with their definition of what this condition is, and they named the condition as slightly different. They called it as MIS-C, multisystem inflammatory syndrome in children. And one difference was that they came up with the age cutoff, which is less than 21 years. So it's not only pediatric population, but also adults which were being affected, young people and young adults. And the rest of the definition was pretty similar to Royal College definition, except that they said that you ought to have multi-system involvement of 2 or more organ groups. And what they also said was that not only the PCR may be positive or negative, but also serology may also be positive, and COVID-19 exposure within 4 weeks would also be sufficient to make this diagnosis. As far as the European Center for Disease Prevention and Control is concerned, they also issued their alert, but they didn't confine themselves to a specific definition, and they left it to the individual European Union state countries to come up with their own definition. And finally, World Health Organization then produced their alert and their definition of multisystem inflammatory syndrome in children, which was quite similar to what Royal College and CDC had issued, although their age cutoff was up to 19 years with 3 or more days of fever and 2 of the features of rash, conjunctivitis, shock, myocardial dysfunction, and coagulopathy along with gastrointestinal problems. And they also mandated that child ought to have raised inflammatory markers and no other plausible explanation for the presentation, and also some evidence of COVID-19 infection, whether it's positive PCR or positive serology or antibody test, or contact with a patient with definite COVID-19 infection. As far as treatment is concerned, I think we are still learning about this illness and its management, but the greatest experience is from London, Great Ormond Street, as well as from Spain, Italy, and France. And first thing first, we have to treat shock with fluid boluses as well as with vasopressing agents and inotropes, respiratory support as much as required, and specific treatment then focuses on IVIG, IV immunoglobulins, and usual dose would be 2 grams per kilo, which can be repeated if there is partial or no response. And most of the clinicians also give IV steroids in the form of usually methylpred, 1 to 2 milligrams per kilo, and that can be repeated over successive days, between up to 3 and 5 days. Some of these cases were treated with anti-IL-1. Few cases were also given anti-IL-6, tocilizumab. There's been controversy as to whether or not these children should be receiving anticoagulation, aspirin and other anticoagulant agents. And towards the beginning of these cases and presentation, some of these children also received remdesivir, although its role is rather controversial. And these children also received antibiotic as cover for potential bacterial infection. So all in all, I think the take-home message is that thankfully critical illness and death in children secondary to COVID-19 infection is extremely rare. PIMS-TS is an emerging disease, and we should have low index of suspicion in children and young people presenting with fever, shock, and GI symptoms. We all know that its management is more or less similar along the lines of management of Kawasaki's disease, but in addition, perhaps consider anti-IL-1 or anti-IL-6. Evidence is rather limited, and therefore I think it's very important that we must have a multi-center, multinational trial to try and ascertain the best possible management strategies in this rare but important group of children, which we are seeing in this pandemic era. These are all my references. I'm very happy to share my references and my slides with all the delegates. Thank you very much.
Thank you, Dr. Ahmed. That was an excellent talk. I have learned a lot from your talk, so thank you very much. And I'm sure there are questions coming up. I'm going to hand over to my co-moderator, Dr. Bernie.
Thank you, everybody, for your time and your presentations. I'm sure the participants have found them useful. We are also on Facebook Live, and we've got some questions coming in from Facebook Live, so I'm picking them up as we go through the session. So the next few minutes we are going to dedicate to a few questions and answers from our participants and the panelists. So I'm going to go into the order I have received them. So I'm going to ask Mr. Varaish first to go and unmute himself and then ask the question, please. Mr. Varaish first.
Yeah, just one question and one comment. The question is, thank you so much for such a nice presentation from Dr. Ambreen, Dr. Amara, as well as Mansoor Bhai and Afzal Bhai. The question is, in gynecology case or OPS cases, do you give higher dose of enoxaparin, or is it just a normal prophylactic dose? And secondly, the comments about was, there's a myth which we surgeons have still following without thinking about it, that it may well be a blood-borne disease, which is not the case. So there is obviously, I raised this question with the Royal College when the guidelines came through for air seal and other things during the procedure. And obviously it's not a blood-borne disease, so I don't think there is any vertical transmission within the babies as well as with breastfeeding. So I think that was the comment from that aspect, which we are still debating in general surgery.
So if anybody would like to take that question.
So, I mean, yeah, go on, obstetrician first.
With regards to the question from Varaish about the use of therapeutic doses, I think one has to be mindful that so far we had suspended our planned elective gynecological work except cancer, which we have started resuming slowly. Now, with regards to the use of low molecular weight heparin, I think it has to be adjusted on case-to-case basis, because depending on the risk factors, their blood test, how severe the disease is, if they're positive. But for the elective cases that are non-COVID, it is absolutely fine to use the prophylactic dose rather than therapeutic dose at the moment.
I think second part of the question was there isn't any vertical transmission being reported yet. Well, maybe Mansoor will going to correct me. And so this is thing, and also in the breast milk, there are very odd cases, 1 or 2 odd cases been reported where they've been COVID-19 was being found in the breast milk, but there is. On the whole, there isn't any case series now. Now the question is, most of the women that we're describing, they are getting the viruses in the last trimester of pregnancy. So we don't know in future what will happen if the mother get in the first trimester. Will going to be affect the newborn baby in any other way? We don't know yet. It's a long way to go to find it out what this viruses can cause drastic effect on the newborn babies, on the unborn child. I think this is a whole new discussion, a whole new word. But I quite agree, the vertical transmission is not been widely reported yet.
Mara would like to comment.
I just want to say there have been a few case reports where the neonates were found to have IgM antibodies, even though they were tested negative and mothers were also tested negative. So it is unclear whether that immunity they had acquired was as a response to the infection in the mother, because IgM antibodies do not cross the placenta. So it is, again, as you have already mentioned, Dr. Afzal, that it's unclear. They are looking into the possible correlation, but as I said, there have been case reports where the IgM antibodies were found in the neonates without the evidence of any.
So that raises the question, if it goes through serum or blood-borne, then convalescent plasma should not be the treatment, isn't it? That's my debate has been with Royal College as well. Like, they are suggesting us to use AirSeal and other things, which fine for the protection point of view. But that doesn't make any sense that the virus has got any blood-borne transmission rather than just the antibodies. I agree that they may have developed from I don't know, some other infections, or yes, from the breastfeeding it can go via contact, because if somebody has not cleaned the breast and fed the baby, you can have a transmission, but not via the milk. That's what my concept is.
I think, if I may come in here, I agree that the vertical transmission remains controversial, although there have been odd case reports coming that there might possibly be a vertical transmission. So earlier this month, there was a publication from Italian group where they said that there are 2 possible cases of vertical transmission, one in a term baby and one in a 35-weeker who was born by cesarean section. And both babies at birth had nasopharyngeal swab PCR, COVID-19 PCR positive, with mother being positive, and also placental swab on the fetal side being positive as well. Now, interestingly, both babies, although were admitted to neonatal units, did really well. They didn't require any ventilatory support. They didn't require any specific medication other than just some supportive feeding. So I think with regard to vertical transmission, so far we are reasonably confident that there's no robust evidence of significant vertical transmission as such. And even if there are some individual possible cases that these babies do well. And finally, Royal College of Pediatrics and Child Health is currently undertaking a British Pediatric Surveillance Unit survey on a weekly basis on all the possible or confirmed neonatal cases of severe COVID-19 infection across all the neonatal units in the country, and hopefully we'll learn more about it with the outcome of this surveillance.
Thank you.
Can I come into this
Irfan
one?
Akhtar, would you like to come in now? Irfan Akhtar?
Yeah. Can I come into this one? So we got to have a pragmatic view on what's happening here. If you look at the PC, there are 2 kind of tests which you are going to be doing. One is a PCR test and one is an antibody test. Now, the PCR test is going to look for the viral genome or viral RNA particle, are those spicules which it has on that. Now, it is quite agreed factor that majority of the patients who might have got infection, subclinical, and were not there, or had infection and now recovered, would continue to shed the viral particles, which are going to be picked up as a positive PCR test. So you could argue the fact that they are positive. Like the instructions to all the patients who get discharged from the hospital are very clear, that you continue to shed viruses, i.e. viruses, in a way that from your respiratory system, you continue for about 2 to 3 weeks, and from your GI system up to about 7 to 8 weeks. Now, a very nice paper had come up from New York. I don't know which place it was from that. Does that mean that you remain infective after getting cured? The answer perhaps is no, you don't, because it is the viral particles which are going to be picked up with that, and you continue to develop antibodies as you go through. We are now starting to question whether these antibodies, especially the IgM perhaps is not as great to begin with, IgGs, are they going to give you protection? And if they're going to give you protection, for how long? And they're going to give you protection against all types of viruses or not. So I'm not sure about whether it answers the question about vertical transmission, which is being discussed, but the fact that children can develop antibodies even if they were not infected, but carried the particle in a very subclinical way.
Could be possible. The other big area which we'll be thinking of, like not COVID-19, for example, any other viruses, they do have when the mother get antenatally, they do have a very drastic effect on the unborn child. We don't know, it's a long way to go yet to find it out what else can happen if the mother get it in the first trimester or in the second trimester, or if the mother have some minor symptoms and she get better, would it going to be affect to the child in any way, like their brain development or any other organ development? We don't know yet. It's a long way to go from here. For instance, in the Northern American, like a Zika virus, which can affect, the mother can get it antenatally, the child can be, the brain is affected and they're born with a small head. So about COVID, antenatal infections and the child, it's a few months or few years to come to find it out, more effects on the unborn child.
Okay, Amara.
I just want to add that we haven't seen a sudden increase in the risk of miscarriage in first trimester. So again, like by next year, we'll be able to kind of shed more light on what its impact is. But like any other infection, I mean, understandably, COVID, this viral infection should increase the risk of miscarriage, but we haven't seen, anecdotally, I can say that I haven't seen a rise in the early pregnancy attendances since the disease has erupted.
Thank you very much. We are, as I said earlier, we are on Facebook Live, also Messenger. So I have a question from Ajmal Khan for our pediatricians. And the question is, in your experience with the given COVID pandemic, did you see a similar pattern in children as compared to the adults amongst the BAME community?
Yes, Mansoor.
Yeah, as I said earlier on, thankfully, the overall incidence of in children with significant COVID-19 infection requiring hospitalization has been very low. And in fact, throughout the country, what we have heard is that pediatric emergency departments and pediatric units have been relatively less busy compared to norm for these months. So in fact, many of the departments have been half empty for one reason or the other. However, as I said, those children who had significant COVID-19 infection, and especially children who had PIMS-TS, inflammatory multisystem syndrome, majority of them, yes, belonged to Black, Asian, and minority ethnic group. So yes, there seems to be a tilt towards BAME group in this group of population.
Yeah.
Mansoor, would you like to? Sorry, Salsa, would you like to comment as well?
That's. I mean, it's a very few cases which we have seen in our center. Although this was Wolverhampton was the epicenter, so we have only 2 suspected cases which we sent, and but in the West Midland, BAME populated children are at more risk of the severe spectrum of the COVID-19. That's what's been observed so far. But I must say that there are not many children, so we cannot confirm on these things, but the trend is that BAME children have been more affected.
Right. right. I have a question for Amara and Ambreen from our audience, which is, could you kindly inform them again regarding precautions to be taken when breastfeeding? Amara, you're on mute.
Yeah, the precautions are as like per general advice that women should actually wash their hands and preferably clean the nipple and try avoiding touching the baby during breastfeeding to reduce the risk, and also wear mask preferably so that there is no kind of droplet infection passed on. But as we have already discussed about the risk of virus in the breast milk, but if you look at the advantages, and if you do a risk-benefit analysis, then advantages of breastfeeding far outweigh the disadvantages, and that's why women should be encouraged to breastfeed. Very important to reduce the risk, to improve the immunity in the newborn, as well as bonding, which is very, very important for their future development. So just the general precautions that we offer for general public, hand washing, and wearing a mask.
Thank you. Would anybody else like to add to those comments from the panelists?
No, I think these are the measures need to be taken as basically and need to be continued breastfeeding. And as Amara said, that is so essential for the child. So hand washing, wearing mask, and just carry on working with feeding the child.
Thank you. I'm going to invite our participants, if you would like to ask a question, unmute the mics, please. Unmute the mics, please. So if any of the participants would like to ask a question, please unmute your mic and ask a question. I see Ifti Bhai had unmuted himself earlier. If Dr. Sayyid Yusuf Iftikhar, would you like to ask a question? Unmuting you. I think we're trying to unmute you. If you could unmute from your end, Sayyid Yusuf Iftikhar. I think there's some technical issue. We'll come back to that question. Dr. Naseem Mahmood, you had a question to ask. If you would like to ask your question now.
I think it was more of a comment in a sense that I think Mansoor has had a very excellent presentation from the pediatric experience. I mean, I have only seen 2 patients in our hospital in Alder Hey, and they were actually relevant to the obstetric colleagues in a sense that they were under 3 months, like extended neonatal period, and they just came with very mild symptoms as you would do as a rule out sepsis, and they were not very unwell, and they had COVID testing because of everybody was being tested. And by the time the swabs came back, they were off antibiotics and they were well off. They were to be sent home actually. So I think there is a very spectrum of a milder disease as well, that the children are not very symptomatic, and so not everybody is very unwell. So we have seen those. I think we total had 8 patients in Alder Hey, and these 2 were the smallest in the cohort in a sense. And those, as Mansoor was mentioning, the severe end of the spectrum, who had this kind of a pattern of 3 symptom complex, if you understand, the toxic shock on one hand, and polyinflammatory systemic response, and then atypical Kawasaki. So depending upon which way the predominant symptoms were, if they were Kawasaki, like atypical Kawasaki, they will treat with immunoglobulins. If the toxic shock, they will be treated as a shock. And if they are like more like inflammatory, then they will be with all the inflammatory response treatments that the different varieties have been mentioned. So I think that these are the kind of emerging understanding. And as somebody was asking about the ethnicity of these children, I don't remember any BAME child was with the severe end of the spectrum, as far as I know, out of those 8 patients. Thank you.
Thank you very much. I'm going to hand over to my co-moderator, Ms. Sadal Jafarpoy.
Okay, thank you, Dr. Bernie. Dr. Iftikhar, have you got any questions? I know you raised, you wanted to ask something from our speakers.
Yes, Sadaf, I did, but Mansoor has answered all that question very, very well. It was about Kawasaki disease, and he has covered it so well that there's nothing more I need to ask. Thank you.
Okay, you're welcome. Any more questions from anyone before we wrap up?
I think Dr. Ishaq Sumra from Nottingham might want to have a comment or a question. We are trying to unmute him, but if you could unmute from your end, Dr. Sumra, if you have a question.
We are not dealing with pediatrics in histopathology. We do deal with adult population. There's a lot of unknowns with this virus. Basically, at the moment, it's from the if we look at the pathogenesis now, they're saying probably the virus is more affecting the hemoglobin and the oxygen carrying capacity in humans, basically. And this is why they're saying it's the hemolysis, and that's why the ferritin levels are increased in these patients. As far as the PCR test itself is concerned, the only thing PCR is telling you that somebody had infection. It cannot really tell you about the infectivity of that individual, whether it could be passed on to the people or not from those individuals. There are trials going on, even one in Nottingham is trials going on about measuring the antibodies, the concentration of antibodies in the staff members. The data will come out, but at this, there are, as I said, there are a lot of unknowns about this organism. Thank you.
Thank you. Okay.
Can I just add one final piece of advice for all, everybody in UK as well as in Pakistan, is that please don't discourage parents and children from seeking medical advice if they feel that they are unwell. It's very important, and we have seen odd cases here and there of seriously ill children being kept at home with a fear that they will get or catch this infection. Please don't do that. If you are really worried, you must seek medical advice.
Thank you.
Thank you, Dr. Ahmed. That's one thing never to be forgotten. I would like to thank all the panelists who have joined us on this Sunday morning and shared their experience and expertise.
There's one question left, Sadaf.
Okay, go ahead, Irfan Akhtar.
I'm sure Naseem is still here. Or is he gone?
No,
because I was intrigued that what was the answer from the Royal College to his question about vertical transmission and use of plasmas.
Naseem Mahmood is online.
Yeah, I think that probably is a question mark, if you understand. I think there have been, as people have already commented on that, so I think it's not...
No, it was to Naseem Wadach, I mean, because the plasma is only in the recovery trial.
Sorry, Irfan Bhai, when I spoke to them, and they were quite clear, yes, it's not blood-borne disease, and it's unlikely that it will spread from the blood aerosols. Obviously, if 10% of them goes via GI tract and 90% is via aerosol from the lungs and stuff, and then contact afterwards. So there's no evidence that it's gone through the blood aerosols. So obviously, we are taking extra precaution at the moment because we're dealing with the unknown. But in future, it'll be like Hep B and Hep C. They don't get transferred by other means apart from blood. That's why we get more protection from there. But this one has not proven anything with the blood-borne transmission. So my question with the Royal College people or people represented from them was, why are we using these aerosols and other stuff if that is not the case? So they don't have any answer clearly at the moment.
So
and with the filter we are using, I've started a project where we're using those filters, and we are trying to grow something from there or do a cytology on those filters to see if anything grows up. Clearly, there is no clear history or evidence at the moment.
So Naseem, we do know that the COVID is in peritoneal fluid, and hence the reason of converting to open surgery or using filter if you're using laparoscopy. But the question perhaps was around the use of plasma or blood, because plasma, as I understand, is only part of the recovery trial. You can't give or transfuse plasma otherwise. But for surgical patients, we sometimes have to end up giving blood transfusions. And I don't think there was any guidance against or for it.
That's correct. Thank you, Mr. Akhtar. Thank you. Right. The time is up, I'm afraid. Thank you once again to all our speakers. Thank you so much. It has been a very informative session. I have to say, I'm not a gynecologist nor a pediatrician, but I've thoroughly enjoyed the session, and I'm sure the rest of the participants have done so as well. We would just like to remind all the attendees that the next webinar session is going to be held on Sunday, the 28th of June. And the topic for that is resuming elective surgery in COVID crisis. We will share the link on our Facebook page in due course. And I'm going to hand over to my co-moderator, Dr. Bernie, to say final words.
As Sada said, thank you everybody, to the panelists, to the participants for the presentations, and to the participants for the questions. I'm sure you have found this useful, as we have as well. This is a series of ongoing webinars, and Sada has announced the next one on the 28th of June, Sunday, same time. We've also been receiving questions from Facebook Live and from Facebook and Messenger. So try and also use those social media platforms. I would also always like to thank Yara Nirvatan, the team behind Yara Nirvatan, His Excellency, the Special Advisor for Health for Pakistan, Dr. Zafar Mirza, Osman Mushtaq, and all the other team members involved in it. So thank you if you are listening in. So inshallah, with that, we would like to end this session, and hopefully we will see you again soon at our next webinar. So thank you very much.
Thank you very much to all of you.
Thank you.
Thank you.